My topic today is religion, spirituality, and mental health. Uh, just a couple of comments on this. When I was searching for a topic, I was trying to think of something I'm a little more passionate about, something that was a little different than we usually get, and something that I didn't feel real strong in, so I wanted to kind of strengthen it. And Dr. Chandraya doesn't really know this, but she had a lot to do with me choosing this topic. Not directly, more indirectly. I've got to work with her a lot this year, and every time that we have a new patient, without fail, she asks me, "Did you ask him about religion and spirituality?" And for the first several times, I did not, and it kind of bothered me because it was something that's is important to me. So I thought about it, and I thought this is a good time to kind of strengthen this up, and that's quite of how I kind of got to this. The other thing I want to talk about is, religion, spirituality. We're going to talk about that today, and religion and spirituality is important to me. But I think what's more important to me is the freedom of religion, being able to choose what you want to believe and what you don't want to believe. And this is not a presentation on how to become religious or spiritual, but rather how to incorporate religion, spirituality in our patients and for their wellness. And so I hope all feel welcome today, whether you're religious and spiritual or not. But I want to start off with this disclosure page. I don't have anything to disclose. There's no apparent conflicts of interest. The objectives today are to determine which areas of mental health have a positive associations when integrating religion and spirituality into mental health care treatment, recognize the historical relationship between religion, spirituality, and mental health, identify religious barriers to mental health care treatment, and give examples of resources to overcome those barriers. And finally, give examples of methods for integrating religion and spirituality into mental health treatment. Kind of the overview here is, it's kind of basic things we're talking about, but I hope that you can pull something out of it to help with your practice. But we're going to just start by talking why talk about this, why integrates religion, spirituality into mental health treatment, and then talk about some areas of mental health that have positive and negative associations when integrating into treatment, and kind of talk about a brief history of the relationship between religion, spirituality, and mental health over time, how this has actually led to some religious barriers to mental health care and methods to overcoming those barriers, and then finish on methods to integrate religion, spirituality, and mental health treatment when appropriate. And I do want to stress that when appropriate. That I think it's probably obvious, and we could probably be assumed. I just want to make sure that, if we try to integrate religion and spirituality in their treatment when someone that is not receptive to religion or spirituality, probably will not go well. So that's not really the point. It's more of helping when we find that it could be helpful. And hopefully over the course of this presentation, we will see when it's appropriate to use religion and spirituality in treatment. So I just want to start off this. I really like this infographic. Wellness is kind of a hot topic right now. I really like this infographic because it breaks down wellness into different areas. And I think most of us are pretty familiar with physical wellness, emotional wellness, financial wellness, and we probably could really have a ground rounds topic on each of these areas. This one more focuses on the spiritual and religious side of wellness, and how we can help our patients in that area. I'll start with some definitions. What is religion? What is spirituality? Religion is a system of spiritual beliefs, practices, or both, typically organized around the worship of an all-powerful deity or deities, and involving behaviors such as prayer, meditation, and participation in collective rituals. So usually using prayer, meditation, and then you participate in some rituals. Spirituality is similar but a little bit different, a concern for or sensitivity to things of the spirit or soul, especially as opposed to materialistic concerns. More specifically, a concern for God and a sensitivity to religious experience, which may include the practice of a particular religion, but may also exist without such a practice. Chaplain Wood, I forgot to give him thanks at the beginning here. He was our mentor, my mentor, and he's helped me quite a bit on this, and I really appreciate that. He gave us the residents a presentation a few weeks ago on religion and spirituality, and he had his own definition of spirituality that I really liked, and he gave me some permission to use it today. But he said, spirituality is a way of seeing and being in the world that lends meaning, value, and purpose to one's life and enables one to have meaningful relationships with God or one's higher power and others. It's a way that brings meaning and value to one's own life. And I like that definition. Just a quick overview. These are world religious groups by number. At least this was in 2015. The World Christian Encyclopedia said there are 19 major religions in the world, which are subdivided into 270 large religious groups and many smaller ones. And the Pew Research Center in 2015 reported that Christians are the largest religious group. At the time, there were 2.3 billion Christians, Muslims, 1.8 billion, which is pretty close to the amount of Christians, 1.2 billion unaffiliated, 1.1 Hindus, 500 million Buddhists, and on down. I think the point of this is just, that Christians are the largest religious group in the world, at least at 2015. So kind of want to say, why do we do this? Why is this even a topic? Why is it important for us to talk about integrating religion, spirituality into mental health treatment? And I think the biggest reason is religion plays an important role in American society. According to a national survey by Pew Research, more than 70% of Americans reported being affiliated with a religious group, and 42% attended religious services weekly or almost weekly. In a study of 406 patients from 13 Los Angeles County mental health facilities, more than 80% of the participants reported using religious beliefs or activities to cope with daily difficulties and frustration. And I think that's kind of it right there, that 80% of those in these mental health facilities reported that they use religion to help them cope with their difficulties and frustration. Another study using the National Comorbidity Survey data suggested that a quarter of religious people seek help from clergy as their first treatment contact for mental health problems. I think that's important. I read a lot of articles, and it said this was said that a quarter of people go first to their clergy, their faith leaders, for their mental health problems. The articles I read said that grew substantially during the pandemic, when there was a shortage of mental health professionals and a higher demand due to mental health problems. They couldn't get into their mental health professionals, so they turned to their faith leaders. By 2011, more than 700 studies had investigated the relationship of religion and mental health, with nearly 500 showing a positive association between the two. And then in 2020, an APA resource document reported patients who report religious and spiritual beliefs, and again, I want to stress that those who report religious and spiritual beliefs have been found to have less depression, anxiety, suicide attempts, psychosis, and substance use disorders. In addition, religious and spiritual patients tend to experience a better quality of life, faster recovery from depression, and an overall better psychiatric outcomes. And I think that's what it comes down to is why do we do this? Because those who report religious and spiritual beliefs report overall better psychiatric outcomes. So it's important to remember that when we're working with patients. I do want to spend a little time on this slide, because this is kind of one of my main points that I would like to stress is which areas of mental health have been shown to have a positive association when integrating religion, spirituality, and mental health. It's not all areas of mental health that have shown to have a positive association. I really like this graph here, this table. It's from a review article in 2021. What the authors did is they gathered several articles and reviewed them and put them together and to show which areas of mental health showed a positive association and ones that did not. And they found with depression, when you integrate religious and spirituality in the treatment, it was generally associated with lower depressive symptoms. Anxiety, they had mixed findings with both positive and negative relationships. Suicide, they found that it was generally associated with lower suicidality. Substance use disorders, generally associated with lower substance use. And psychiatric disorders, this is one I kind of found interesting. They said that they found that when a patient with a psychotic disorder, if they had religious delusions, it was associated with a poor prognosis. If they did not have religious delusions, it was generally associated with better outcomes. And so that raises the question a little bit. If you're seeing a patient, you're admitting them, and they have religious delusions, and you admit them, do you get a chaplain involved? Do you not? Do you help them? And I actually sat down and talked to Chaplain Woods about this. How he addresses those that are psychotic, religious delusions, and the chaplains are trained to work with psychotic patients, and so yes, if a patient is asking for a chaplain and they have religious delusions, you can place a chaplain consult, because they are trained to be able to work around that, and we really appreciate that. But I found that interesting, that those with religious delusions are associated with a poorer prognosis when integrating religion and spirituality in their healthcare. OCD had few studies, but they were mixed. Bipolar was a few studies, but it generally associated with better outcomes. PTSD is generally associated with better outcomes, and eating disorders had mixed results. So overall, the ones that clearly showed a positive association were depression, suicide, substance use disorder, psychotic disorders when there's not religious delusions, bipolar disorder, and PTSD. So I want to turn to kind of see if we can do this, a little bit of a discussion. I know it's a little bit more difficult when on Zoom than in person, but I'd like to get your thoughts, at least a couple of your thoughts on a couple different scenarios. It's not intended to be a deep discussion, but just kind of your thoughts. There was an article in 2019 titled "When Religion Reinforces Stigma, a Call to Bridge the Gap." And the author opened up with two different scenarios, and then he gave his opinion on the scenarios and what he thought, what it meant. And so I'd like to just kind of open up with one of those scenarios and I'd like you to share your thoughts on how you feel about them. And the first scenario it's real basic. A young man contemplating suicide is told by a pastor to pray. So we have a young man suicidal, goes to his faith leader, and he tells him that he needs to pray, and that would help his suicidality. Do you guys have any thoughts about that? Do you think that's appropriate, inappropriate? Okay to do? And the interesting part about these scenarios, I actually asked some faith leaders in the community about what they thought about these scenarios too. And I think it's interesting to compare their perspective versus mental health professionals' perspective. Is there anybody that would like to comment on that?
I think, Jared, it would really depend on having more information, what the patient's or the individual's relationship with God, religion is, and how much the intensity of the affiliation with religion, if there is, might help to support not committing suicide, and trying to work with that. So you want to work with the pastor in positive ways, but hopefully that's not the only thing that would have been said. But really the intensity, because a lot of times people that may be depressed or having difficulties, unfortunately, may question their faith. And it's really important to be aware of that. And if there's a possibility of helping them actually regain some of the faith that may help them, that used to be a strong influence in their life, that's a great thing to do, but you've got to do that very cautiously, making sure you're not going to aggravate and have them feel that they weren't getting the help they were looking for.
Thank you. Thank you. That's kind of my first, exactly kind of what my first thoughts were too. But anybody else have any other thoughts on this? And it really is basic. We don't have a lot of information.
Well, one thing, Jared, is I agree with Dr. Chandrea, 100%. But the flip side of this is that this is absolutely happening out in the world.
Mhm.
Being somebody who's interested in suicide prevention research, I mean, this is a pretty important thing. People turn to their clergy a lot of times for assistance, and then they're told to turn it over to God, or to take it to prayer, and there may not be those referral systems. And some of the more successful intervention efforts for communities have actually involved training clergy members to be able to make referrals, or to be able to kind of really quickly triage crisis moments for the people that come to them. Because there's been many examples of people who've been told to really rely on their religion and spirituality to the exclusion of mental health services, and I think that's a real danger.
Thank you. Thank you. Yes. And I appreciate that. Anybody else have any other comments they'd like to say? I found this interesting. I found it interesting when I talked to the faith leaders. When I told them this scenario, most of who I talked to said, "Yeah, that's very appropriate." And they have worked with patients that have been, or they don't call them patients, but worked with members of their congregation that have been suicidal, and they have done this. They've helped them pray, and they've helped them get through it. Praying helps have a strong relationship with God, and help them through it. So they were on board with that. I tend to agree more with what has been said, and involving mental health, or at least a certified social worker when appropriate. But the second scenario, a little bit different, is said a woman with complex post-traumatic stress disorder, nightmares, and hypersensitivity to suspected abuse is encouraged to think about her symptoms as demonic in origin and tell negative thoughts to go back to the pit of hell. So we have a woman with PTSD that's symptomatic, and her clergy, her faith leader, is basically told her to tell her, change your thoughts and get rid of those thoughts. Anybody have any thoughts about this scenario? And if not, that's okay. This one I was very, very pleased to hear what I heard from the faith leaders in the area. The first scenario, yeah, they said yes, that praying is okay. That I think that is good. This scenario, everybody I talked to recognized that this patient was symptomatic for PTSD, and they needed a lot more help than what they could offer, and that they would reach out to mental health with this scenario. So what the author concluded with the first scenarios, religious leaders may warn against seeking out mental health professionals. The second scenario, he said there's a subtle message that she lacks faith in God, and both which are not good for the patient. And overall, he concluded each of these cases is a representative of a phenomenon believed to be common across the world's faiths, religiously reinforced mental health stigma. So this kind of takes me into the next section here. We talked about where there's positive associations when we integrate religion, spirituality into mental health treatment. But what about if are there times where it can adversely affect treatment? And the answer to that is yes, there are times. I really like this statement from Dr. Farah Abbasi, that she gave at a UC Berkeley forum. And I don't know if you don't know who the Dr. Farah Abbasi is, I would encourage you to look her up. She's a faculty at Michigan State University. She's a member of the Muslim Studies program there, and she's nationally recognized for her work in minority mental health. And I saw her name quite a bit when I was doing research on this. But she said in 2020, faith leaders and mental health providers can be natural allies, as both propagate the same wellness and well-being goals. And I believe that's true. I think that the faith leaders and mental health providers, a lot of times we have the same goals, the wellness and well-being goals. Sometimes ethical concerns are the most significant breach that is hard to navigate. Many religious institutions still lack a hard stand on sexual orientation and same-sex marriage. This inclusion is seen in rejection and can exacerbate the mental health of the LGBTQ population, leading to higher rates of substance abuse and suicide. Suicide and substance abuse can be seen as moral failures in underlying pathology if underlying pathology is not understood or taken into account. We need to train more trauma-informed congregations where the cognitive shift can happen from what is wrong with you to what wrong happened to you. Generally religious and spiritual beliefs are associated with better psychiatric outcomes. However, they can cause harm when they support behaviors such as treatment refusal. And even in this area, there's a drug rehab that we often use, especially when we're discharging patients from Woodridge, that they will not allow us. They're a Christian-based rehab, but they will not allow us. They'll not allow the patients to take psychotropic medications while they're there. And so when we use the rehabilitation center, we'll usually give the patient, like a long-acting injectable, long-acting antipsychotic, or where we can get the medications in when they don't need it. But that can cause a problem. Other times when they're shamed, especially with our LGBTQ population, or justification of harm, such as abusing family members or negative religious coping, attributing all problems to the devil. So I think it's important, there's clearly some positive associations when we incorporate religion and spirituality into help to treatment. But we also need to be aware that there are some times where it can adversely affect mental health treatment. And as our jobs as mental health professionals know when it's appropriate to incorporate it and when to pull back and change things a little bit. So I want to change gears a little bit, and I want to talk about give a brief history, just the history of the association, how mental health and religion, spirituality has associated over the years. And this isn't supposed to be a comprehensive history. That some of the textbooks I read gave a comprehensive history, and they're really good. And there's a lot of interesting stuff in there, but I mostly just wanted to pull out some specific areas that gave a brief overview of what the relationship between mental health and religion was at a particular time. Before I say that, I just want to say different religions have had different approaches towards mental health. This presentation focused primarily on the European and North American Christian tradition, because it is this tradition that has most influenced modern psychiatry's way of dealing with religious and spiritual issues. The textbooks talked about, the way that the Buddhists or Hindus or other religions approach mental health. Very interesting, and if you're interested in that, I encourage you to go read about it. But this presentation has more to do with the Christian tradition. Historically, psychiatric disorders were explained by supernatural phenomena such as demonic possession. And until the late 18th century, early 19th century, religion and psychiatry were closely connected. Churches were generally responsible for the care of the mentally ill. And that just makes sense. For centuries, they believed it was a supernatural phenomenon, demonic possession that caused psychiatric disorders. If that was the cause, then, let's turn to churches because they'll be able to help. But that was the case until the late 18th century and the early 19th century. The history of psychiatry has often been told as the emergence from the transition from superstition to reason, from religion to science, and that only in the modern era have we come to understand that madness is not the result of spirits, demons, and curses. So going back to the 2nd and 3rd century, this was, at that time, early church writers generally respected the work of physicians. They had a view of madness that included a spiritual perspective while also acknowledging physical influences that cause mental distress. And this was shown in the writings of John Chrysostom. He was a bishop and highly regarded preacher. He wrote a series of letters to a deaconess named Olympus, who suffered from bouts of despair. The letters spoke of how her physical illness often caused despair. He believed her physical illness was caused by her sense of dejection. He rebuked her for taking pride in her sorrow. He recommended that she pray and learn to recognize her blessings. So, this is a scenario where he recognized that her physical illness was caused by her sense of dejection, and not by a supernatural phenomenon or demonic possession. And he was able to recognize that. And coming up to the 16th century, until this time, again, the churches and mental health were pretty closely tied together. But in the 16th century, we started to see a little bit of a separation from it. In 1548, Reginald Scott, who was an Englishman, a member of Parliament, authored a book titled The Discovery of Witchcraft. The book reflected a point of view that started to take hold in the 16th century, that people who are sad or distressed suffer from natural malady and not from supernatural influences. He spoke about the treatment of the insane and how religious reasoning was used by families to help those suffering from religious delusions. In the 17th century, Puritan writers wrote about a practical way of dealing with psychological distress. Anglican priest named Richard Baxter authored a book called Christian Directory. It was about depression and Christian life. It contained a lengthy set of instructions on treating depression. He rejected the idea that the devil was responsible for melancholy. He counseled those who were depressed should spend less time in religious activities so that their religious duties would be less burdensome, and to seek cheerful company. And he also said, commit yourself to the care of your physician and obey him. In the 18th century, philosophers and physicians began to think the soul less in religious terms and more in philosophical and scientific terms. Those treating the mad began separating religious causes from the other causes, and religion and spirituality became a category of madness. Also in the 18th century lived Philip Pinel. He's a physician in France, who many consider the father of modern psychiatry. He's known for developing a more humane approach to the care of psychiatric patients, referred to moral therapy. He worked towards abolishing the shackling of mental health patients by chains. But he distanced himself from religious views and felt religion could be harmful. And he separated the religiously delusional patient from others. He encouraged physical activity, to devote their time to philosophical readings. And he removed them from view of anything that could remind them of religion. He recognized that patients with religious delusions did not respond as well when integrating the religion and spirituality into their treatment. And he ended that, and what he found was that patients would get better quicker and be less admissions. And hospitals, and this isn't written in here, but the writing said hospitals in the area started to take note, and they started removing everything that was religious or spiritual from their hospitals. He didn't want to go that far, but some of the hospitals around him did. During this time, religious beliefs led to asylum reforms in other parts of the world. In 1790, there's a Quaker widow was admitted to asylum due to melancholy. But while admitted, local Quakers tried to visit her to offer spiritual aid, but they were denied access. And it had swung so far that even Quakers were not even allowed to visit those that were admitted to give spiritual aid. She died 6 weeks after being admitted. Her death was concerning for many. This led to Samuel Tuke, who was a mental health reformer. He created a model of having a physician provide medical treatment and allowing laymen to offer religiously oriented therapy. Somewhat kind of what we see today. Today we have a physician provide medical treatment, and at least in the hospital now we have the chaplains instead of the layman to offer religious oriented therapy. This was the model most of the United States chose to follow at the time. During the late 19th, early 20th centuries, the belief that psychiatric disorders were a result of supernatural influences was no longer seen in medical writings and most records of treatment. The focus of religion began to disappear from most of European American psychiatry, even in the countries that had been affected by religious reform. Psychiatry began to be more focused in heredity and biology. During this time, there was an increased interest in hysteria. A major change occurred when psychiatrists began associating religion with hysteria and neurosis. This led to a divide between religion and mental health care. Psychiatry began attacking religious experiences. Many mental health professionals in Western societies began considering religion as irrational, outdated, and dependence forming, and a cause of emotional instability. This division continued until more recently. And this is the time that we really started seeing a separation between churches, religion, and mental health and psychiatry. Arguably the most important influence of this period was the work of Sigmund Freud. And his view of religion set the tone for the psychiatric view of religion, particularly in the United States, for much of the 20th century. And a little about Sigmund Freud, and I'm not here to he did a lot of great work, and I'm not here to badmouth him or anything. I just want to report on what his beliefs were. But he was an atheist. He viewed religion as a shared delusion, helpful for some, harmful for others, but ultimately something that was an indicator of psychological immaturity. He said religion was the way in which humans came to terms with the fear of death and the concern about meaningless. He believed that religion was a common but false belief, and that God was a projection of internal desires. And he wrote that religion was a delusion of the masses that could relieve some anxieties, but that fostered immaturity and restricted choice. But also important to recognize that not all psychiatrists at the time held that same belief, Carl Jung being one of them. But then in the late 20th century, there began to be less opposition to religion. And this is kind of when we started seeing the pendulum swing back a little bit. In the 1940s, 1950s, the non-religious but spiritual-based Alcoholics Anonymous came to prominence. In 1968, the Committee of Psychiatry and Religion of the Group for the Advancement of Psychiatry published a report noting the positive influence of religion on mental health. In 1999, the Royal College of Psychiatrists began the Spirituality and Psychiatry Special Interest Group. The World Psychiatric Association established a section on religion, spirituality, and psychiatry. A Journal of Muslim Mental Health was founded, and peer-reviewed journal articles on religion grew substantially. We're seeing, for centuries, religion and mental health, and psychiatry were closely connected. And then starting in the 16th century, more than the 18th, 19th centuries, there was started to be quite a separation. And then in the 20th, 21st century, they've come back together a little bit. And this leads us to kind of where we stand today. In 2006, an APA resource document stated that psychiatrists should maintain respect for their patients' beliefs, and that psychiatrists should not impose their own religious, anti-religious, or ideological systems of beliefs on their patients, nor should they substitute such beliefs for accepted diagnostic concepts or therapeutic practice. And this, I believe, the statement still stands today. In 2016, the World Psychiatry Association published a position statement on spirituality and religion and psychiatry, urging the inclusion of religion and spirituality on clinical encounters and training with the goal of providing a more holistic and comprehensive form of mental health care. So again, we had the close connection of them, the separation. We're kind of come back to working together, but with the separation, it has led to some barriers in mental health care treatment, and I want to kind of touch on some of those barriers for a minute. Due to psychiatry historically being known to have an adversarial relationship with religion, this has led to religious barriers to mental health care. Because religion and spirituality can play an important role in healing, patients with mental health concerns often turn first to their faith leaders. And we've talked about this in the previously, that a lot of at least a quarter of patients go to their faith leaders first before they'll turn to mental health care professionals. Religious leaders have various beliefs about psychiatric care and the perceived need for treatment. And we kind of saw those with the different scenarios that we talked about. Their perception of psychiatric disorders can lead to avoidance of referral to mental health professionals. In a survey conducted among 204 Protestant pastors, many of them attributed symptoms of depression to a lack of trust in God, and they were less likely to agree with the biological nature of depressive disorders. Another study conducted of Muslim clergy showed they recognized the need for psychiatric care, but were reluctant to make referrals to mental health due to concerns about discrimination based on their religion. Additional concerns have arisen during inpatient treatment. An observational study conducted by SUNY Downstate Hospital, orthodox Jewish patients at the psychiatric inpatient unit experienced difficulties due to conflicts with the religious practices. Studies showed that inability to pray at accustomed times that exacerbated the anxiety of religious patients. For an outpatient treatment such as psychotherapy, patients had fears that the therapist would challenge their religious beliefs. And we saw this. I've seen this in my own family. We have a close family member through marriage that really struggled with pornography. He was the father of several children. He worked at a government facility, and he would view pornography on his work computer. And it led to him losing his job, losing his security clearance with the government facility, and he was out of work for at least 2 years with several children. And he, in his words, his viewing pornography led to 2 counts of infidelity, and he really struggled with it. He reached out to mental health, went to a therapist. And I was not there to witness it, but he came back from after his therapy session and said the therapist told him that there's nothing wrong with pornography and he should just continue to view it. And that was very hard on him because he'd made that step to try to go, and that some of the barriers that we face as patients fear that therapists would challenge their religious beliefs. And he ended up going back to his faith leaders and being able to overcome that pornography struggle. But this is recognized, and there's been a lot of work to try to overcome these barriers. And this is something I really like. In 2014, the American Psychiatric Association Foundation partnered with the APA and the Interfaith Disability Advocacy Coalition. So the APA and the Interfaith Disability Advocacy Coalition, they created a partnership to try to overcome these barriers, and their partnership was called the Mental Health and Faith Community Partnership. And it's a collaboration between psychiatrists and clergy aimed at fostering a dialogue between 2 fields, reducing stigma and accounting for medical and spiritual dimensions as people seek care. And together they created a guide titled Mental Health, a Guide for Faith Leaders. And this is the second point that I'd like to spend a little more time on. First point was those areas of mental health that have shown a positive association when we integrate religion and spirituality into treatment. And the second point is I'd like you to be aware of this guide they gave, because if you have a foot in religion and foot in psychiatry, there's probably going to be a chance that you are going to be asked by your faith leaders to address mental health concerns at a church or wherever you may be. I know this happened to me. My intern year a couple of years ago, I was at church and we had a patient with schizophrenia come in to church, and our faith leaders asked me to address his concerns. And at the time, this member of the congregation had some concerns with his schizophrenia. I had to, tread lightly. I have a training license, not a full license. I couldn't act as a psychiatrist at the time. But I quickly observed him and made sure that he was not psychotic or needed admission. But then was able to talk to him, arrange for him to be with his sister and his wife's sister. His sister's husband was a physician in New York, and we were able to get him up there to be stabilized. And I thought that was everything was okay. But then a few weeks ago, when I was doing a rotation or a call on Woodridge, he was a patient there, and he saw me. He recognized me. In that scenario, I could work as a psychiatry resident, but he didn't want to see me as a psychiatry resident. He wanted me to see me as a faith leader, and he took it. He was struggling, questioning his faith, and he saw me, and he took it as a sign from God that he should pursue his religion. But I was able to sit down and talk to him, and at that point took more of a stance as a psychiatry resident rather than a chaplain or clergy leader. But it does happen. You're probably going to need to help congregations if you have that, or if you have a patient that wants to include their clergy, their faith leaders in treatment. This is a great resource that you can give the faith leaders. And what this is it's a guide. They also made a 2-page brochure that I know that Chaplain Woods uses. And this is a free download. The purpose of this guide is to provide information to help faith leaders work with members of their congregation and their families who are facing mental health challenges. I just want to kind of take a quick look through this book. It's not meant to read. If you're looking this on a phone, you probably can't read it all. If you have a computer, you probably can read some of it. But the book is broken down to 2 parts. The first one is just kind of mental health overview. It explains what mental health illnesses are, and helps educate clergy or faith leaders on mental health. The second part is for faith leader support for people with mental illness. So if you have someone in your congregation that does have a mental illness, how can you help them? And again, this isn't meant to read because you're probably not going to see it. But if you look up here, there's this first part is just what is mental illness, and then it talks about different mental health illnesses and kind of gives them a description of it, and then it talks about suicide and what we should do with it. And what I like about this book is it does talk about praying and support, but if a patient is suicidal, they really need to have some mental health professionals involved. The second part is if you have somebody with a mental health concern, what can you do for it? How to refer the patient, where to refer the patient, and also it has a section on how congregations could be more inclusive and welcoming. So just keep that in mind that the APA has put out a book to help local congregations, local faith leaders to learn about mental health and how we can work together rather than against each other. And I think it's a great resource. So this kind of turns to the end, the last topic that I want to speak about today. And this is just kind of how do we integrate religion, spirituality, and mental health treatment? So we talked about kind of the why, the history behind it. Now we get to how do we do it? There was a 2007 study that showed that compared to other physicians, psychiatrists were more likely to be without religious or affiliation and less likely to frequently attend religious services, believe in God or the afterlife, or cope by looking to God. So the study showed that psychiatrists were less likely to be religious. By comparison, a 2014 survey showed that 83% of adults were absolutely or fairly certain that they believe in God, and that 77% of adults say religion is important in their lives. And a study in 2017 found that a third of Americans do not believe in God, but believe in a higher power or spiritual force in the universe. So we have two studies here. One shows that psychiatrists are more likely to not be religious or spiritual. And then you have a study showing that most adults in America are religious or spiritual. And these studies suggest that patients who prefer to see like-minded psychiatrists may have difficulty finding a match. So the kind of question arises from this: how do we support a patient with differing beliefs? And this is not a new thought. I mean, we approach this all the time. How do we support a patient with differing beliefs? And so how do we do this? So mental health professionals should maintain respect for their patients' religious and spiritual views, including their values, beliefs, and worldviews. It's important for mental health professionals to ask patients about their religious and spiritual commitments in order to properly assess, formulate, and treat their mental health needs. An effective way to accomplish this is by taking a spiritual assessment of patients at the beginning of treatment and throughout treatment when appropriate. And there's several spiritual assessments we can do. There's two of them that I found that I really like. A lot of the things that I read about talked about this hope questions for spiritual assessments, and it specifically talked about residents using it. Other one I found that I really liked is called the FICA Spiritual History Tool. And basically, you can use these spiritual assessments when you're seeing a patient, first time or later on when you feel it's appropriate. And if we're familiar with these assessment tools, what they do is they allow for rapid screen of religion and spirituality, and they're real easy to do, and it's kind of a rapid screen. And when followed, it helps clinicians avoid assumptions about a person based solely on their religious affiliation by exploring the patient's unique beliefs, the importance of these beliefs to the patient, whether they share these beliefs with a community group, and how they would like their beliefs to be addressed in care. And that's what I really like about this FICA spiritual history tool. And, FICA we're not talking about the Federal Insurance Contribution Act that we see with our taxes, but FICA here stands for faith, importance, community, address. But I really like that last question is how would you like your psychiatrist to address these issues in healthcare? Because we can easily ask the patient, are you spiritual? Are you religious? But that doesn't necessarily mean that they want us to address that. And when we ask how would they like to address these issues, then we get an idea of how we can best help them. But again, the F stands for faith and belief. You can ask them, do you consider yourself spiritual or religious? What importance does your spirituality have in your life? And has your spirituality influenced how you take care of yourself and your health? Community, are you a part of a spiritual community? And then the last, address in care, how would you like your psychiatrist to address these issues in your health care? The hope questions for spiritual assessment is similar. I'm not gonna really go over it a lot. But what I don't like about this questionnaire is it doesn't have a question about how you would like to address in the healthcare, although you can just add it if you'd like to. So it kind of brings us to the end here. You have a patient that wants to integrate spirituality and religion into their treatment. And if you ask them how they want to do it, you get an idea of how to do that. But I think it's important to come back to say, as mental health professionals, the responsibility is to provide medically and sound treatment according to psychiatric standards of care, regardless of spiritual commitments or religious affiliations. So even if the patient comes back and they say, I want to do just pray for my suicidality, our job is to provide medical sound treatment. And if we're able to develop a strong therapeutic alliance with them, that'll help us overcome. It can help discourage harmful and dangerous practice associated with religion and spirituality, such as when a patient's religious and spiritual beliefs conflict with the therapeutic goal and clinical indicated treatment. And so we know how we can ask them, how can we help them? We know that. What other things can we do? And the biggest one is if they're inpatient, place a chaplain consult. And I missed this several times. The first couple of years of residency, a lot of patients I would wait for them to tell me they wanted a chaplain consult, which looking back on it now, I wish I would have done an assessment when I was seeing them in the emergency room, or when I was seeing them the first time, ask them about their religion, spirituality, and if they were interested in that time, to integrate religion and spirituality into their treatment. At that time, I could have placed a chaplain consult, and it's a great time to do that. And at least at the VA, only board certified chaplains and students in that process are permitted to conduct spiritual assessments proper. The chaplains do an excellent job with the patients, and I've seen them do great work. There were times up on E2 where I had a more difficult time getting that patient to really talk to me. But once we got a chaplain involved and I was able to talk to them about the chaplain, they opened up a lot more, and I always really appreciated that. Other things you can do, various forms of spiritual augmented cognitive behavioral therapy have been proven effective when used appropriately. Might be a little bit more harder to find. It's someone that can do spiritually augmented cognitive behavioral therapy. I know that several religious organizations have certified or therapists that can do this. And the other areas would be alert to situations when patients' religious and spiritual needs would warrant referral to religious and spiritual community when their needs may be more fully met. So that just kind of takes me to the end here. Some take-home points. It's important for mental health professionals to assess and understand the religious and spiritual values of their patient as part of their treatment. Just as other areas of wellness are incorporated in treatment, religious and spiritual values should be too. Remain open-minded about a patient's preference for non-harmful but spiritual valued practices as adjunct treatment, and know the areas of mental health that have shown positive association when integrating religious spirituality into their treatment. Areas such as depression, suicidal ideation, psychosis, where there are no religious delusions, substance use disorders, PTSD, and bipolar disorder. Remember that guidebook, Mental Health, A Guide for Faith Leaders. It's a free download. If you need a physical copy, you have to pay for it, but it's a free download for an electronic copy. And remember to take a spiritual assessment when evaluating a patient, such as the FICA and HOPE screen. And I just want to end with a shout out to our chaplains, especially Chaplain Wood, and remember to place that chaplain consult when it's indicated. And so these are a reference, and just like to say thank you for sitting through this, and wondering if there's any questions.